Hello everyone, this is Dr. Seher from DentaBest, your best online mentor for the preparation of IMBD, ADAT and AFK exam. So today in this Udemy video, I have taken up an important topic of exam, that is human anatomy, and I've tried my best to give all the important concept, basic fundamentals covered of this vast subject using this video. So as per the dental exams that we are covering, that is IMBD, ADAT, AFK, DCOR or DHA, we are mainly focusing on head and neck anatomy. So let us try to dig in more in this video and see what all contents I have covered in this video. So first of all, we are going to start this video with cranial anatomy, the anatomy of the skull, the cranial fossa, important cranial foramina, like which foramina, which nerve structure passes through it, like foramen spinosum, foramen rotundum, and the other foramens through which the important vital structures are exiting. Then we have the ethmoid and the sphenoid bone, which are important bone of your facial structures. Then the two most important bones for us as a dentist is the maxilla and mandible. Everything about these bones, their parts, and if we have any important foramens or fossas, they are making boundaries of for the maxilla. Then the mandible, everything about mandible, the parts of the mandible, what are the ligaments that are attached, like at the temporomandibular joint that it is making, the foramens, mandibular foramen. Then we have the lingula as a part of it. Then we have the cavernous sinus, right? And especially we discuss about the danger triangle of the face, that how the infection from the danger triangle of your face can spread to the cavernous sinus and can lead to cavernous sinus thrombosis, leading to brain infections as well. Then the circulation of the CNS, the CSF, where we discuss about different types of ventricles. So how the CSF is flowing from one ventricle to another ventricle, the different foramens involved there. The circle of Willis, that is the blood supply to your brain. What are different arteries involved in circle of Willis. Oral cavity, everything about it, different structures here. The facial spaces, the orofacial spaces, like your space, sublingual space, your submental space, submandibular space, the infections of these space that we are going to cover actually in oral surgery. The TMJ is a very, very important topic of exam. Everything about TMJ we should know, including the structure, nerve innervation, the blood supply. The TMJ disorders again will come in oral surgery. And the attachments to the hide muscles, the hide bone, the blood circulation to the face, a very, very important topic of exam, where we discuss about different branches of external carotid artery, the venous drainage, plus the lymphatic drainage in the face. We discuss also about the thyroid gland, which is the important gland present in the neck, the laryngeal cartilages, including the epiglottis, and what is the different nerve innervation for the larynx. So here we discuss about different parts or the different structures related to the vagus nerve. So I hope you will really like this video on human anatomy, and don't forget to give me a review so that I keep on posting these kind of helpful video to make you ready for your preparation of IMBD, ADAT, AFK exam. Thank you so much and wish you all the best for exam.
Hello everyone, this is Seher again from DentaBest, and I'm here to discuss some concepts on human anatomy. As we know, this is a very important subject of exam, and we are going to discuss human anatomy. As we know, it's a very vast subject in two videos. So this is the first video that is starting with, we can see some of the contents here, like cranial anatomy, osteology, fossas, cranial foraminas, the cranial bones, maxilla, mandible, sinus, CSF circulation, blood-brain barrier, oral cavity, the facial spaces, temporomandibular joint, the masticatory muscles, TMJ imaging, hide, external carotid, the blood circulation to the face, and the venous drainage along with the laryngeal nerves. Okay, so let us see this first slide where we have the cranial anatomy and osteology. So as we know, the cranium is divided into neurocranium and viscerocranium. A neurocranium that encloses your brain, and viscerocranium that comprises your face. And we can see there are different bones here in neurocranium, like frontal, parietal, temporal, occipital, sphenoid, ethmoid, and viscerocranium is made up of maxillae, nasal bone, zygomatic, palatine bone, lacrimal bone, concave, vomer, mandible, and the hide bone. Mainly in the exam, they can ask you more questions about which of the bones are fused and which of the bones are paired and which of the bones are unpaired. So that is an important thing that we can remember from here. Okay, so here on this slide we can see different views, like inferior view of the skull, superior view, we can see the lateral view, the right and the left lateral. So these are useful pictures, you can go through them. Now we can see there are different cranial fossas. We have the anterior, middle, and the cranial fossas, but the middle cranial fossa, as we know, is the most important. So you should know the contents of it, the temporal lobe, pituitary, optic, superior lobeal, orbital fissure, carotid canal, ganglia, and what are the bones that are forming the cranial fossa. That's the greater wing of sphenoid bone and the petrous and the squamous portion of the temporal bone. Okay, so here we can see the important cranial foramina, the bones where they are present and what are the contents passing through them. So it's an important page. You can go through that as well. Now we can discuss about two important bones here, the ethmoid and the sphenoid bone. We know these bones are single, unpaired, midline, and they are bilaterally symmetrical bones. These are the two bones which contribute both to the neurocranium as well as the viscerocranium. You can also see the components of them, like cribriform plate, crista galli, lateral plate, perpendicular plate. But the important one in respect to exam is cribriform plate, olfactory foramina, the cranial nerve number 1, olfactory nerve that passes through it. And then we have the lateral plate that contain ethmoid sinus and lamina pepericea, which is a paper-like bone. For the sphenoid bone, we have the component of hollow body, greater wing, lesser wing, medial lateral pterygoid plate, hollow body where we have sella turcica, the seat of pituitary. That's important. The lesser wing which has the optic canal, and the medial and the lateral pterygoid plate. So we know both the masticatory muscle, medial and lateral pterygoid muscle, they're attached to the lateral pterygoid plate. And the medial pterygoid plate will extend and form a hook-like structure called as hamulus. So tensor veli palatini is going to get attached there. Now we know the zygoma refers to as the malar bone or the cheekbone, and the zygomatic arch is formed by temporal process of zygomatic bone and the zygomatic process of temporal bone. Now we can see the maxilla. So this is important. As we know, maxilla is the upper jaw and consists of body and 4 processes: the zygomatic, frontal, alveolar, and palatine. Is going to form foundry of 3 cavities: the palate, floor and lateral wall of the nose, floor of the orbit, and form 2 fossae, infratemporal and pterygopalatine, and form 2 fissures, infraorbital and pterygomaxillary. Now here in the infratemporal fossa and pterygopalatine fossa, the most important thing you should remember the contents of them. Boundaries are not asked in the exam. And the pterygopalatine fossa and the major communication. Here also we can just remember the direction of them, like lateral, AP, posterior, superior, medial, inferior, and what are the contents passing through them. Passageway and the space is not important. Now we can see the hard palate here. So hard palate, it forms the roof of the oral cavity and the floor of the nasal cavity. And the hard palate is made up of palatine process of maxilla that makes the anterior 2/3 of the palate, and the horizontal plate of palatine bone that makes the posterior 1/3 of the palate. And as we know, in the interior of the hard palate, behind maxillocentral incisor, we have the incisive foramen that's also called as the scarpa, midline, tension, or the lateral foramen. So the nasopalatine nerve block is given in this papilla area. Now we can see the nasal cavity. So sensory innervation of the nasal cavity is from branches of V2, that is maxillary division of trigeminal, nasoorbital, infraorbital, and the greater palatine. And the blood supply is from sphenopalatine branch of maxillary artery, anterior ethmoidal ophthalmic, and septal branch of superior labial. You can see different boundaries of nasal cavity, but the medial wall of the nasal cavity made up of nasal septum, as we know, that is the most important. Now we can see different systems and the location of drainage for the concaves and the meatuses. The important one we have the maxillary sinus that drains in the middle meatus of the nose, and the nasolacrimal apparatus that drains in the inferior meatus of the nose. Now this is important. It is called as Kieselbach's plexus, that is supplying the anastomosis of 5 arteries are the Kieselbach's plexus. And why it is important? Because the epistaxis or the nose bleed, it mainly happens from this Kieselbach's plexus. You can also remember the maxillary sinus. It is lined by Schneiderian membrane, which is a type of pseudostratified columnar epithelium. Now we can see about the mandible. So this is important. As we know, the mandible is the largest and strongest bone of the face, and which houses the lower teeth. And the part of the mandible, we have the body, rami, cornoid process, condylar process, angle of the mandible. And on the mandible, on the medial side of the ramus of mandible, just below the lingula, we have the mandibular foramen, where the inferior nerve, artery, and the vein is going to pass through. Also, we should know the mental foramen that is located below the second premolar area. So mental nerve, that's the last branch of inferior nerve. It passes through it. Now, this is a very good table of the meninges, where we can see dura mater, arachnoid mater, and the pia mater. Mainly in the exam, they ask you about, like, if you have injury to the middle meningeal artery, we are going to have epidural hematoma. If we have injury to the bridging vein, we will have subdural hematoma. Now, subarachnoid hemorrhage, it doesn't happen due to head trauma. It mainly happens because of rupture of aneurysm or dilated artery, like anterior communicating artery, which can get ruptured due to excessive stress, hypertension, and that can lead to subarachnoid hemorrhage. That is also called as worst headache of my life. One thing also we can remember here, the subarachnoid space, which is filled up with the CSF, and the circle of Willis is running here. So if you have to do the lumbar puncture or spinal tap, we are going to penetrate the subarachnoid space to take the CSF out. Okay, so on this slide, we can see different type of meninges. We know it's a very important topic. We have three: dura mater, arachnoid mater. The innermost that is enclosing the brain is the pia mater. So mainly in the exam, they ask you that if you have injury to, let's say, middle meningeal artery, you will have hematoma in the epidural space, like that. If you have injury to the bridging veins, you are going to have the subdural hematoma. Now, subarachnoid space is where the CSF is circulating. So if you have to do a lumbar puncture or spinal tap, we have to reach the subarachnoid space. And subarachnoid space hemorrhage can lead to worst headache of my life. Subarachnoid hemorrhage is not due to head trauma. It is mainly due to a rupture of the dilated aneurysm or the artery that can happen due to the hypertension. So we can see a good picture here about the veins. You can see the bone, dura mater, arachnoid mater, all the layers here. Now, cavernous sinus, as we know, it's a very, very important topic of exam. We always have questions from the cavernous sinus. You should know everything about the cavernous sinus, the location, the anterior-posterior connection, what are the contents of cavernous sinus, what's present in the lateral wall, what are structures that are running through cavernous sinus, and important point that from here the infection can spread directly to the brain because it has connection with all the cranial nerves. We'll discuss more about it related to the danger triangle of the face. So what is danger triangle of the face? This triangle, it runs with the apex at the infraorbital region and the base at the upper lip area. So why this area is called as danger triangle of the face? Because the veins which are draining this part of your face, like your ophthalmic vein, pterygoid plexus, maxillary vein, they don't have the valves in them. If they don't have the valves, the blood can flow backward. So from the sinus, from this part of the face, danger triangle can go to the sinus, and from the sinus can directly spread to the brain, leading to thrombosis or brain infection, zygomycosis. Now this is the pterygoid plexus of vein. You should know the location, what's receiving and draining. This is also an important topic. Now this is how the CSF is circulating, right? So we know CSF is produced by the ependymal cells lining the ventricles or the choroid plexus. The important thing here is the flow chart from where to where, so starting from lateral ventricle to third ventricle to fourth ventricle, and what are the name of openings in between, like foramen Monro in between, third ventricle, fourth ventricle, cerebral aqueduct in between, then subarachnoid space, fourth ventricle, foramen Magendie and Leshka, and finally the CSF is going to empty in the venous circulation. It's going to circulate along with the venous blood in your body. Now we can see the circle of Willis. So circle of Willis is the closed loop of arteries that is providing the oxygenated blood directly to the brain. So you can see the principal arteries here, the feeder arteries, the branches, and the supplies of them. And the important point that is here is the middle cerebral artery, which is the largest branch of ICA, and if blocked, it can cause the most ischemic injury. Now, one of the branch of middle cerebral called as lenticulostriate artery is very commonly involved in stroke, because it's very thin walled and can easily get ruptured. Now we can see here the anatomy of the oral cavity, and we can see this is a very good picture. It has good details here. Now we can see here the components of oral cavity is the oral vestibule and the oral cavity proper. And we can see that the posterior termination of the oral cavity proper, it is called as a palatoglossal arch. So that's an important question that can be asked in the exam. Now let us talk about the general sensations of the tongue, taste sensation, chorda tympani, and the components of it. So nerve innervation of the tongue to understand, we know that the tongue is divided into anterior 2/3 and the posterior 1/3 as we can see in the picture. Now anterior 2/3 is innervated by chorda tympani for the taste sensation, and for general sensations lingual branch of V3. For the posterior 1/3, both the general and the taste sensations we know is innervated by glossopharyngeal, and for posterior most part of the tongue or epiglottis part of the tongue is innervated by 10th, and the muscles of the tongue are innervated by hypoglossal, except the palatoglossal muscle that is innervated by 10th. On the inferior surface of the tongue, we can see the Wharton duct or the Rivian duct. Wharton duct is the opening for submandibular gland and Rivian is for sublingual gland. Now, one thing that is important here when we talk about the taste perception, there is this nucleus in the brainstem called as superior salivatory nucleus of ductus solitarius. The nucleus of tractus solitarius is the nucleus in the brainstem that is going to perceive the taste sensation and going to give it to thalamus, the VPM nucleus of thalamus. And from here, the taste sensation are going to go to the gustatory cortex in the parietal lobe where the taste sensations are going to get perceived. Now, one more important point about the superior salivatory nucleus. Superior salivatory nucleus in the brainstem is providing parasympathetic secretomotor fiber to your submandibular, sublingual, and also to your lacrimal gland. Now, we can see different types of taste buds: filiform, fungiform, circumvallate, foliate. Filiform papillae, we know they are most numerous. They give the rough texture to your tongue. So tongue has to be rough. If it is smooth, that is called as glossitis. That can be sign of vitamin deficiency, mainly vitamin B12 or riboflavin deficiency. So this filiform papillae, they don't have the nerve supply, they don't have the blood supply, and they do not have any taste buds either. Fungiform papillae, they have the taste bud. They're scattered among filiform. The circumvallate papillae are present right at the V area, right? So you can see here, these are small circumvallate papillae, and this is the V of the tongue. This is anterior 2/3 and that is posterior 1/3. So circumvallate papillae are spread around the V, sulcus terminalis, and the tip of sulcus terminalis we have the foramen cecum, that's the remnant of thyroglossal duct. This is the posterior most part of our tongue where we have the epiglottis. We can see the lymph node or lymph drainage of the tongue as well. As we know, the tip of the tongue where it retains, answer is submental group of lymph nodes. So that can be asked in the exam. One more point important about the circumvallate papillae is that the circumvallate papillae, they are associated with von Ebner gland, that are minor salivary gland, which has serous secretion or watery secretion just like your parotid gland. Okay, so now we can see the muscles of the tongue, which are the extrinsic and the intrinsic muscles of the tongue. Extrinsic muscles are your palatoglossus, genioglossus, hyoglossus, and styloglossus. So they have origin from some bony origin and insertion on the tongue. They are going to move the tongue, like protrude, depress, pull tongue upward, backward. And we can see all of them are innervated by number 12 except palatoglossus, which is innervated by number 10th. Or the pharyngeal plexus. Pharyngeal plexus is actually the interdigitation of three nerves, 9th, 10th, and 11th, on which the 10th is considered to be the principal component of it. But the intrinsic muscles, they are going to change the shape of the tongue itself because they are making the tongue. And we have the longitudinalis here, transversus, verticalis. They're all innervated again by your 12th nerve hypoglossal. And we can see here, these are the muscles, these are the hard palate bones, we already discussed about them. They are covered by keratinized mucosa, and soft palate is entirely muscular. It has only muscles like palatopharyngeus, glossus, levator palatini, tensa palatini, uvula. These are the muscles of the soft palate we have. Now, one more thing that is important in the soft palate muscles definitely is that submucosa. and the insertion of the soft palate muscles is on the palatal aponeurosis. So that can definitely be asked in the exam. The innervation we can see is from pharyngeal plexus and from V2, that is maxillary division of trigeminal, and the blood supply is by greater palatine artery from the greater and the lesser palatine foraminas. You can see here the blood supply of it. So greater palatine artery travel with the nerve and vein from greater lesser palatine foramen, and sphenopalatine vessels. They travel with the nasopalatine nerves, and they arise from incisive foramen. Now we can see here the uvula that is suspended from the soft palate. An incomplete fusion of palatine shells can give rise to bifid uvula. So if you have unilateral damage to the pharyngeal plexus, it can shift the uvula to the contralateral side. Now, what are fascias? Fascias are the soft fold of the muscles, and fascias are between anterior and posterior pillar, and between both pillar we have the palatine tonsils which are present. Now, the anterior pillar, palatoglossus muscle, posterior pillar is made up of palatopharyngeus, and the functions of both palatoglossus and palatopharyngeus we should know. Like palatoglossus draws the tongue and soft palate closest together, while palatopharyngeus will elevate the pharynx, help close the nasopharynx, and aids in swallowing of it. Now the next one we have are the tonsils. We can see there are different types of tonsils here, like pharyngeal tonsil, palatine tonsil, and the lingual tonsil. As well as we are seeing the location here, like pharyngeal tonsils, they are nasopharynx, adenoid, the palatine tonsil between isthmus of palatoglossus, palatopharyngeus, and lingual tonsil are on the dorsum of the tongue posteriorly. We can also see the tensor veli palatini and the levator veli palatini, that are the muscles of the soft palate. What are the insertion action of them? Action definitely is more important. When tensor veli palatini, you can see tenses palate and open the auditory tube with the mouth opening. That's an important point here that we can go through it. And definitely the levator veli palatini will elevate and raise the palate during the swallowing. Now, pharyngeal muscles, we can say there are two groups of pharyngeal muscles. This group of pharyngeal muscles are actually the constrictor muscles of the pharynx, in which we have superior constrictor, middle, inferior, and cricopharyngeus. And origin is not important, but insertion, you can see all of them are inserted in midline pharyngeal raphe. And their main action is to contract in ways so that they can push the bolus of the food deeper from pharynx into the esophagus. And we can see the innervation, the sensory, and the motor of them. The second group of pharyngeal muscles we have are the longitudinal. You can see here the palatopharyngeus, salpingio, and the stylopharyngeus. You can remember the insertion of palatopharyngeus, that's on posterolateral pharynx, and then the stylopharyngeus. The salpingopharyngeus arise from cartilage or eustachian tube. We can see both palato and stylo, they raise the pharynx and larynx during swallowing, while salpingopharyngeus, it has a typical function of elevating the nasopharynx, opening the auditory tube, and equalizing the air pressure between the pharynx and the auditory canal. Now you can see the nerve innervations too of them. Now this is a very important section. We should know the phases of swallowing. So we have three phases here: the oral phase, the pharyngeal phase, and the esophageal phase. The oral phase, we can see the nerves involved is CN5, mastication, tongue involved CN12. In the pharyngeal phase, the tensor veli palatini by CN5, palatoglossal levator veli palatini by CN10. First step in pharyngeal phase is to close the nasopharynx, then elevate the pharynx and the hide bone. That is your stylo, palato, and salpingio are going to do it. The longitudinal muscles, then closing the pharynx, then the epiglottis get retroverted, vocal cords get closed, and finally the bolus of the food will pass from pharynx to the esophagus by the relaxation of cricopharyngeus muscle that act as the upper esophageal sphincter. And finally the food will be in the food pipe, that is esophageal phase, peristalsis, and larynx, pharynx, and hide bone, they will relax again and come back to their natural or original position. Now we can see the different types of salivary glands, the parotid, submandibular, and the sublingual. But before that, we can see some points about the lacrimal gland too. lacrimal gland where the tears are being produced that go into puncta, then into the canal, then into the sac, and then into the nasolacrimal duct. While the lacrimal gland, paired serous gland that is involved in tear production, parasympathetic innervation. So superior salivatory nucleus, greater petrosal nucleus, and the lacrimal nerve. So superior salivatory nucleus, as I told you, innervated by 7, is providing parasympathetic secretomotor fiber to the lacrimal, and all the glands, the preganglionic and the postganglionic is a very important section. So number 7th branch, greater petrosal branch of number 7 give preganglionic, and lacrimal branch of V1 will give postganglionic to the lacrimal gland. Now we have the other important 3 major glands like your parotid, submandibular, and the sublingual. Again, for these glands, their duct structure is important, and the innervation, as we can see, preganglionic and the postganglionic. So preganglionic, lesser petrosal branch of CN9, postganglionic leaves otic ganglia with the auriculotemporal branch of V3. Submandibular gland, we can see preganglionic chorda tympani branch of 7, and postganglionic leaves ganglion passes to the gland. For sublingual, it is exactly the same, the preganglionic and postganglionic. Now the synapse of parotid gland is in the otic ganglia, while submandibular ganglia is for submandibular and sublingual, both of them. Okay, so here on this slide we can see the salivary gland. We know the 3 major salivary gland we have is parotid, submandibular, and sublingual. Mainly in the exam they ask you about the duct structure or the innervation. So parotid gland, we know it's a Stenson duct that opens opposite maxillary second molar, while submandibular and sublingual gland opening both happen at the sublingual caruncle or papilla behind mandibular central incisor in the floor of the mouth. So Wharton duct is a duct for submandibular gland, and sublingual gland ducts are called as Rivian duct. One of the last size Rivian duct is called as the Bartholin duct, and both Bartholin and Wharton duct, they open at the same location. Most important is the preganglionic and the postganglionic here for parotid, submandibular, sublingual. Since submandibular, sublingual are very closely associated, you can see both of them are having the same preganglionic and the postganglionic. The synapse ganglia is otic for parotid, submandibular ganglia for both submandibular and sublingual gland, and as we know for lacrimal gland, the ganglia is pterygopalatine. You can also see the minor gland like von Ebner gland, serous only saliva, and gland of Blanding and Nunn, which is mixed serous and mucousy. Okay, so on this slide, we can see different facial spaces. We know these are the important spaces we have: parotid, submandibular, sublingual, tonsillator, and masticator. We are not going to do the boundaries, just the contents is enough. You can memorize them, like carotid sheath present in the parapharyngeal space, retropharyngeal space. As you know, that space can get infected in Ludwig angina, right? It can cause breathing problem to the patient, creates an emergency condition. Now we can see some of the facial spaces, like we have the parotid, submandibular, sublingual, your tonsillar, masticator, pharyngeal space, the different spaces we have. In these spaces, the contents of these spaces are, okay, so not the boundaries, but contents is the most important section we have that you can go through it. Now when we talk about the mastication and the TMJ, it's a very, very important topic. And the 4 primary muscles of mastication: masseter, temporalis, median, lateral pterygoid. So very, very super important table. Everything about the origin, insertion, and action you should be knowing, and what are they involved in: opening, closing, protrusion, retrusion. What are the primary muscles in each of these actions, and what are the accessory or helping muscles at the same time. Now we can see the TMJ structure too. So TMJ structure, it has it's a bilateral synovial joint, and this joint is formed from the mandibular condyle and the skull base on both the sides. So it is a diathroidal joint. So by articular disc, this joint is divided into upper joint compartment and the lower joint compartment. The upper joint compartment, which is between the disc and the glenoid fossa, and the lower joint compartment will be between the disc and the condyle. Lower compartment is for rotation and upper compartment is for translation. So we can see different components of joints are there: glenoid fossa, articular cartilage, articular disc, meniscus, condylar cartilage cap, and condyle of mandible. It also has the ligaments and the articular capsule that is surrounding the joint. So bony component here becomes the condyle of mandible, mandibular fossa which is concave, condyle of mandible which is elliptical, posterior condyle is rounded and convex, and enteroinferior aspect of condyle is concave. This concavity is called as fovea pterygoidea. It's the entero-superior aspect of the condyle that is going to be articulating with the glenoid fossa. Now, articular eminence is present on the anterior part of glenoid fossa. It's a small convexity, anterior to concavity of the glenoid fossa. And one thing we know, it's a very important thing here, that although TMJ is a synovial joint, but it is not lined by hyaline cartilage, it is lined with fibrocartilage. So that is one thing that is exception. Now, articular disc, as we know, it's a very important structure. It's a fibrocartilaginous biconcave disc and lies between the condyle and the mandibular fossa. And this is the one that divides the joint cavity into superior and inferior. Now, there are different regions of the articular disc we have, like thin zone, thick anterior posterior band. Posterior band has some tissues attached to it that is called as bilaminar zone. Bilaminar zone is the only zone of TMJ which is vascular and innervated. So this is an important point that you can go through it. Now there's a capsule that is surrounding the entire TMJ. It has a lining of synovium, and this membrane is going to secrete the synovial fluid for lubrication of the joints. Now the TMJ imaging, that is the next one we can see. The bony structure we can image by pano, CT scan, or the plain films, while the soft tissues like MRI, it would be required for the soft tissue, especially the position of articular disc. The nerve innervation, the most important nerve innervation to TMJ is definitely auriculotemporal nerve that conduct the primary innervation to it. Now the different ligaments of the TMJ we have, like temporomandibular ligament is there, which is a primary ligament of the TMJ. It has two parts, outer oblique that prevent posterior inferior displacement, and inner horizontal that prevent lateral or mesial displacement. Then there are two helping ligaments too, like sphenomandibular and stylomandibular. Sphenomandibular is a remnant of Meckel's cartilage, and stylomandibular, it connects styloid to mandibular angle. Sphenomandibular is going to limit the maximum protrusion of your jaw, and stylomandibular limit the maximum opening of your jaw. Now we come to the neck anatomy, the cervical anatomy, where we can see starting with the cervical vertebrae, which is from C1 to C7. Now we have two joints here, atlantoaxial and atlanto-occipital. Atlanto-occipital is the first joint in your body for the yes movement up and down, and atlantoaxial is from shaking the head right to left, that is the no movement between the atlas and the axis. Now we have different layers in fascia of the neck, in which deep cervical fascia is the most important, and it has three layers: investing layer, pretracheal, and the prevertebral layer. In these three layers, mainly they ask you about the thyroid gland, where it is located. You should know it is present in the pretracheal layer. Now let us talk about the carotid sheath. That's an important structure, and that is made up of common carotid artery, internal jugular vein, the 10th nerve. Carotid sheath, it extends from the base of cranium to the root of the neck. It is blending with investing and pretracheal fascia anteriorly and with prevertebral fascia posteriorly. We can also see different triangles of the neck. So we have the posterior triangle and the anterior triangle. So in all of these triangles, actually the boundaries and the boundaries, actually you are skipping the contents, which are the most important one we have. So we can see the posterior triangle, and there you can see the anterior triangle. Anterior triangle also, the contents are very important. We can see the anterior triangle have different subsets. Like the first one we see is the submandibular triangle here. Again, the contents of it. Then muscular triangle content, carotid triangle contents, submental triangle contents, muscular triangle contents of them. Now there are two muscles here, SCM and trapezius, in which the SCM is, both of them are innervated by 11th. We should know their action: flexing the neck, unilateral pulse head to shoulder, head to opposite side. So injury to SCM can lead to torticollis or stiff neck position. While trapezius helps in extending the neck, elevating acromion, or rotating your shoulder, chin up to opposite side. So trapezius paralysis can lead to a shoulder droop condition. Now we can see different hide attachments. What are different muscles that are attached to hide bone? All the names, and you can remember also the innervation of them. That's also important. And these are the muscles, supraoid and the infraoid group of muscles. Supraoid muscles, action, innervation. We have digastric, anterior belly, posterior belly here. We have mylohyoid, genioid, stylohyoid. You should know the actions of all of them and the innervation of all of them. They are all raising the hide bone, the base of the tongue, and the floor of the mouth. While the infraoid group of muscles are like omohyoid, sternothyroid, thyroid, and they all have the action of depressing the hide bone and the larynx, and they're all innervating. Like ansa cervicalis is the innervation, that is cervical division of motor division of cervical plexus, that is innervating the infraoid group of muscles. So let us talk about cervical plexus. Cervical plexus run from C1 through C4. It is going to give cutaneous innervation to the skin of neck, shoulder, and anterior upper chest wall. It is motor to the infraoid group of muscle and also motor to genioid. Now there are three branches of cervical plexus: phrenic, supraclavicular, and transverse cervical. It's a phrenic that mainly give the sole motor innervation to your diaphragm. Now we are coming to a very important section, that is the blood supply to the face through the external carotid artery. So the common carotid artery at the level of superior border of thyroid cartilage is going to branch into internal carotid and external carotid. Internal carotid will travel upward, supply your brain, and give only one branch near the on the face near the eye, that is your ophthalmic artery. All of the branches of internal carotid is inside the brain. The rest of the head and neck is all supplied by external carotid. So external carotid is a very, very important topic. We should know everything about the course of it, the branches of it, the supply, and especially when they are given you terminal branches of any artery or nerve, that is important. For example, in case of external carotid, we can see superficial temporal and the maxillary artery are the terminal branches of it. So everything we are doing here, we are not skipping anything in the external carotid. Now one of the branch of external carotid, the lingual. We should also know at what level, like lingual artery originate from external carotid at the greater horn of the hide bone. What is supplying, what are the branches of lingual artery? That is also important. So the last branch of lingual artery is the deep lingual artery. Now we can see the next. Okay, so we can see the branches of lingual artery, right? And where it is supplying, very, very important. So it originates from external carotid at the greater horn of hide bone in the carotid triangle, where all it is supplying the tongue, sublingual gland, floor of the mouth, and all the branches are important. And as I told you, the most important, they ask you the terminal branch of the artery. For example, the terminal branch of lingual artery is the deep lingual artery. So this is a good picture that will help you in understanding. Next one, that is your facial artery. Again, facial artery, the portions of it, cervical, facial, the branches of it, the supplies of it, and we can very well see the last branch of the facial artery is the angular artery that's going to anastomose with the ophthalmic artery. The maxillary artery is also very important artery. As we know, it is divided into three parts by the lateral thyroid muscle. It supplies your muscle of mastication, maxillary and the mandibular teeth, palate, and most of the nasal cavity. So this entire table of maxillary artery, the three portions, mandibular, pterygoid, pterygopalatine, the branches, supplies, and definitely the last branch of pterygopalatine, that is sphenopalatine, that give rise to nasopalatine and come out through the incisive foramen in the anterior palate. That is an important one. Now the venous drainage of the face, we should know all the veins that are draining the face: superficial temporal, maxillary, retromandibular, external jugular, and mainly in the exam they ask you like which veins are draining into which vein, or which vein is drained by which other veins. This is all important. You can memorize the names of the face, veins of the face, what is the venous drainage of the face. Especially in the exam, we can have the questions of the common facial vein or external jugular. And this is a very nice flow chart that is given here, that is giving you all the facial venous drainage. That is important. Now we can see the lymph node in the face. in which the most important one actually we have is the submandibular and the submental group of lymph nodes. Although you should know all the lymph nodes of the face, they're draining into jugulo-digastric, then going to jugulo-omohyoid. Now we can see the thyroid gland here. It's a S-shaped gland at the laryngotracheal junction at the anterior neck, and it has two lobes, right and left, which are joined by isthmus. Now this gland is going to produce the thyroxine hormone T3 and T4. It has the follicular cells which are producing this hormone, and also it has the parafollicular cells which are producing the calcitonin hormone. That calcitonin hormone is going to decrease your blood calcium and works just opposite to parathormone. So parathormone is produced by the parathyroid gland. So you have two superior and two inferior parathyroid gland. Two superior parathyroid gland, they develop from the fourth pharyngeal pouch, and inferior they develop from the third pharyngeal pouch. So when we do physiology hormones chapter, we'll talk more about these hormones, PTH, your thyroxine hormone, calcitonin. Now fourth and third pharyngeal pouch, again in the embryology section, we'll discuss about the derivatives from these arches or pouches or clefts, what all different structures are being derived. Also we can see the blood supply and the drainage. For example, superior thyroid artery, branch of ECA, and inferior thyroid artery, branch of thyrocervical trunk, is the blood supply to thyroid, and veins, superior, middle, inferior thyroid veins, and they finally drains into internal jugular vein and the brachiocephalic. Parathyroid gland are very small gland close to the thyroid gland. They're small pea-shape, and they will have the same blood supply as thyroid because they're located very close to it. As I told you, parathyroid gland is going to produce parathormone. So if you have deficiency of parathormone, it can lead to tetany because of less calcium. So we can see the blood supply on this slide here. Now let us talk about larynx. So larynx is responsible for voice production, and these are the following 9 cartilages that we have in the larynx: thyroid, cricoid, epiglottis, arytenoid, corniculate, and cuneiform. So out of 6, 3 of them are paired and 3 of them are unpaired. Thyroid cartilage is the largest cartilage that forms Adam's apple, that is more clearly visible in the males. And cricoid cartilage is the only cartilage that form a complete ring around the airway. All of the cartilage are in the C shape, but cricoid is like a complete ring around the airway. Now in the exam, they also ask you what's the posterior attachment of vocal cord. You can answer arytenoid cartilage is the posterior attachment of the vocal cord. Now epiglottis is a thin leaf-shaped cartilage covered with the mucous membrane at the root of the tongue. It's a flap closing over the larynx when you're swallowing the food, so the food doesn't enter into your voice box. Now you have the vestibular folds and the vocal fold. So vestibular folds are the one which are protective in nature. They don't produce any sound, while your vocal folds are the true vocal cords, which are going to involve in the voice production, and they are made up of vocal ligament and the vocalis muscle. So we have the extrinsic and the intrinsic muscles of the larynx. And the extrinsic muscles of the larynx are your suprahyoid and the stylopharyngeus muscle, in which suprahyoid and stylopharyngeus are going to raise the larynx, while infrahyoid are going to depress the larynx. In the intrinsic muscles of the larynx, we can see there are cricothyroid, posterior crico, lateral crico, transverse, oblique, arytenoid, and the vocalis. We don't have to remember their origin and insertion, but we should know the actions of them. Like cricothyroid stretches, tenses vocal cord. Posterior, lateral crico, one abduct, while lateral will adduct. Posterior will abduct the vocal fold. So abduction means it will open up the vocal cord, and adduction will close. Vocalis is important, relaxes your posterior vocal ligament and acts as an antagonist of the cricothyroid muscle. Important is the innervation too. You can see all of them are innervated by recurrent laryngeal, except the cricothyroid, which is innervated by external laryngeal. Both internal laryngeal and external laryngeal, although, are branches of vagus. Now we can see some points about the recurrent laryngeal nerve and the superior laryngeal nerve here. So as I told you, both are branches of vagus. And recurrent laryngeal, it comes off the vagus in mediastinum and ascends to the larynx in the tracheoesophageal groove. The most important point about the recurrent laryngeal is that it has a close association with the thyroid gland and the inferior thyroid artery. Now left recurrent laryngeal will wrap around the aortic arch, while right recurrent laryngeal will wrap around the right subclavian. The recurrent laryngeal nerve is going to give motor innervation to all the intrinsic muscles of the larynx except your cricothyroid and give sensory innervation involving laryngeal mucosa below the vocal fold and the upper trachea. While your superior laryngeal nerve, that's a branch of the vagus again, it will arrive just after exit from the jugular foramen. It passes through the thyroid membrane. It has again two branches, external branch and the internal branch here, where external branch will innervate the cricothyroid as we know, tenses the vocal cord and increases the pitch, while internal branch will provide the sensory information to the laryngeal mucosa above the vocal fold. Okay, so let's wait and we are going to do the second slide or second PPT of anatomy, which has neuroanatomy, oral embryology, and also oral histology in it.